بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين. السلام عليكم جميعا. شكرا على الاستضافة مرة ثانية، وأنا بعتذر عن التأخير الحصل بالنسبة لبعض المشاكل التقنية. إن شاء الله our topic today it will be about the TI-RADS of the thyroid nodule. And actually the word TI-RAD stands for Thyroid Imaging Reporting and Data System. And so today, inshallah, first I will try to explain for you the concept of the TI-RAD and how to apply it. And then we'll go through some cases in order to make us more familiar with the TI-RAD. So as we all know, ultrasound is the first modality for the assessment of the thyroid nodule. And many times when we have patients do CT or MRI for another reason than CT than thyroid, and they have incidentally a thyroid nodule, they send this patient for more characterization of this nodule by ultrasound. This means ultrasound is superior to the CT and MRI for characterization of the thyroid nodule itself. But CT and MRI, it will help more in the assessment of the neck lymph node. Thyroid, it has medium level echo with texture similar to that of testis and liver parenchyma. And both thyroid lobe, it will appear more echogenic than the surrounding neck muscle. So if we compare the echogenicity of the thyroid to the sternocleidomastoid muscle, we'll find that the thyroid, it is more echogenic. And this point actually it is an important, because later on when we have nodule in the thyroid, we are going to compare the echogenicity of this nodule to the thyroid itself and then to the neck muscle. Nodule are one or more area of the thyroid with different echotexture than surrounding parenchyma. And I think easy for anyone of us when scanning thyroid to tell if there is nodule or not. And actually most of these thyroid nodule are not palpable. And in daily practice, when we are scanning patient for the thyroid nodule, the vast majority of this nodule we are detect are benign. Only few percentage are malignant. So this lead many investigators around the world, they try to bring for us stratification system that help us to determine which nodule it need FNA and which nodule it need follow up. And actually the idea it came after they found the BI-RAD. Maybe most of us they try the BI-RAD, especially the female sonographer. The BI-RAD which it used for the give a score for the breast lesion. After they found it is widely spread and it helped in the diagnosis of the breast lesion, they bring for us the TI-RAD. And actually nowadays even there is liver RAD and ovarian RAD. So we have RAD for each organ, whatever we use CT, ultrasound or MRI. So the importance of the TI-RAD, it came because now we all work under one frame. It helps us to determine what to do with this specific nodule, either follow up or to take biopsy or no action at all. So the white paper of TI-RAD, it came to us in 2017, and they give us the TI-RAD chart. So here I have the TI-RAD chart, and all our lecture today, it will be about this chart. So if we get familiar with it, after that we will be able to apply the TI-RAD. And actually this chart, we recommend to put it in your ultrasound room, in your reading room, so you can memorize it when you are scanning the patient. And in the TI-RAD, we have 5 categories in the top. We have composition, echogenicity, shape, margin, and echogenic foci. So the idea simply, we are going to expose the nodule to all these 5 categories and start to give him feature. So if the composition is solid, I'm going to give it 2 point because it is unsolid. Then I will move to the echogenicity and I will give it point. Then I will go to the shape, then the margin and the echogenic foci. And I'm going to give one feature from each category. Except for the echogenic foci, I can add more than 1 point because a single nodule, it can has macrocalcification and microcalcification at the same time. So after I start to add this point, this it will give me the TIRAD level, which start from the TIRAD 1 until TIRAD 5. And for TIRAD 3, 4, and 5, we have a size threshold, which later it will determine for us which action we will do, either FNA or follow-up. And in the bottom, we have an explanatory note for each category. So we have a 5 TIRAD level, and from TIRAD 3 to TIRAD 5, it will be mildly suspicious, moderately, and highly suspicious. So if the overall score is 3 points, it means the nodule corresponds to TIRAD 3, which is mildly suspicious. In this case, if the maximum diameter it is bigger than 2.5 or equal to it, I'm going to do FNA. And I will follow if the diameter it is equal to or bigger than 1.5 and less than 2.5. And if the size of the nodule it is less than 1.4, 1.5, no action I will do at all. And for TIRAD 4, which it consider moderately suspicious, I will do FNA if the size of the nodule equal to or greater than 1.5, and just I will follow if the size it is equal to or greater than 1 centimeter and less than 1.5 centimeter. For TIRAD 5, when we have 7 point or more, which it consider highly suspicious, I will do FNA if the nodule is greater than or equal to 1 centimeter, and I will follow if the size is greater to or equal to 0.5 and less than 1 centimeter. And for TIRAD 1, it will be benign and no FNA at all. And for TIRAD 2, we'll consider it not suspicious and also no FNA it will done. So now I will explain each category. So for the composition, we have like 4 feature. Either the nodule is cystic, and in this case, I will give it 0 point. So as we all know, the cyst, it should be benign. It will be benign. So we'll give it 0 point. And thyroid, it has spongiform cystic appearance, spongiform nodule. And when we say spongiform, we mean that more than 50% of the nodule it composed of cystic space. So if we concentrate in this nodule here, we'll find that it composed of cystic space more than 50% of component of this nodule. And in order to make sure that we are dealing with spongiform nodule, we can put our color box, and it should be no flow at all. So if I have mixed cystic and solid nodule, like 50% cystic and 50% solid component, like nodule here, I have this nodule which composed of 50% of cystic space, and it has this thick septation. So I will consider it mixed cystic and solid, and I will give it 1 point. When I have a nodule completely solid like this, I will give it 2 points, or almost completely solid. Here I have solid nodule with tiny cystic space. And in order to say this nodule solid, it should be more than 95% of the component of the nodule solid component. So the second category in the TIRAD, it will be the echogenicity, and either I have anechoic nodule, also I will give it 0 point. If I have a hyperechoic nodule, I will give it 1 point. And here actually I'm going to compare the echogenicity of the nodule to the ipsilateral parenchyma. So here when I compare the echogenicity of this nodule to the rest of the thyroid, I will find that the nodule, it is hyperechoic compared to it. And in this case, I will give it 1 point. And actually, even also if you scan patient with autoimmune disease, like it has thyroiditis or Graves' disease, and the thyroid, it is an already hypoechoic, you have to compare with the echogenicity that you have. Here I have a nodule. When I compare it to the rest of the parenchyma, it looks isoechoic, and also I will give it 1 point like hyperechoic nodule. For the hypoechoic nodule, I will give it 2 points, and here I have a nodule. It's relatively hypoechoic to the rest of the thyroid parenchyma. For the very hypoechoic nodule, I will give it 3 points, and it will be more suspicious. And in this case, I will compare the echogenicity of the nodule to the adjacent neck muscle. So here when I compare the echogenicity of this nodule to the strap muscle, I will find that this nodule, it is more hypoechoic compared to the muscle, and even here and here. And actually sometime the nodule hypoechoic, it has acoustic enhancement. And in order to make sure that you are not dealing with cyst, if you put your color box, you will see the vascularity. So the question, it will be, when I have a mixed nodule composed of cystic and solid component, I will compare the echogenicity of the solid part to the rest of the thyroid. So here I will compare the echogenicity of the solid non-calcified part of the solid component to the rest of the thyroid. And here when I compare the solid component of the nodule to the thyroid, I will find that I have an hypoechoic nodule. Sometimes I cannot tell the echogenicity or the composition, and this, it will be due to peripheral calcification that obscure the content of the nodule. So in this case, I will add 2 points for the composition, and I will add only 1 point for the echogenicity. So for the shape, either I have nodule that is wider than taller or taller than wider. And actually, I'm going to assess this in the transverse view, and only by visual inspection I can tell this nodule, it is longer than wider or the opposite. And when we have the nodule which is wider than taller than wider, like this nodule, it means this nodule, it invades the adjacent parenchyma, so I will start to worry about this nodule. And I think that for any nodule, whatever in the kidney or ovary, if the AB diameter, it is more than the width, it will be invasive. So when the nodule is wider than taller, I will give it 0 point, and when it is taller than wider, I will give it 3 points. And the question, it will be, when I have nodule the AB diameter equal to the width, what point I should give? Like here I have the AB diameter, it's almost 1.14, and the width 1.14. So in this case, I'm going to say this nodule, it is not taller than wider, and I will give it 0 point. So the fourth category that we have, the margin. Either the margin, it is an smooth Like this nodule, it is an easily to distinguish the margin from the adjacent parenchyma. So for the smooth margin, I'm going to give it 0 point, and also for ill-defined margin, when it is difficult to distinguish the margin of the nodule from the adjacent parenchyma, you will give it 0 point. For irregularity or lobulation, when I have nodule with speculation like this and irregularity, I'm going to give it 2 points for this irregularity, and it shouldn't be cover the whole margin of the nodule. It could be just in a small portion of the nodule. Even when we have lobulation like this, I will give it 2 points. And no need to waste your time to determine if it is this lobulation or irregularity, because both you are going to give it 2 points. The last thing we have in the margin, when we have nodule with extrathyroidal extension, and we mean with that the nodule extends through the thyroid margin itself. And nodule like this, we are going to give it 3 points. But if the nodule it just do only bulge in the capsule, we will give it 0 point. So the question it will be, what I will do in case like this if I have mixed cystic and solid nodule. So which side I will determine the margin, from outside or inner side. So this it will depend on the distribution of the solid component. So if the solid component distribute like this, you are going to assess the margin from outside of the nodule, which here it consider smooth, so we'll give it 0 point. But if the solid component like this and this look like mural projection, in this case you are going to assess the margin from the solid component of the nodule, which it appear irregular in both this nodule. So the last category that we have, the echogenic foci, and as I mentioned, in this category you can add more than 1 point. So either we have large cometal artifact like this and this, and we mean by large, here we have calcification with large cometal artifact greater than 1 millimeter, and I think here we have spongiform, so we are dealing with cystic nodule. Here we have true cyst with this large cometal artifact. Also here we have cystic structure with large cometal artifact. So this large cometal artifact, we will see it with cystic nodule. We will not worry about it, and we will give it 0 point. Macrocalcification, when it is enlarged enough to produce acoustic shadowing, and we will give it 1 point. For the peripheral calcification, either it is completely or partial around the nodule, and we will give it 2 points. And the last thing, it will be the punctate echogenic foci or microcalcification. It will be like dot-like throughout the nodule, and it will be less than 1 millimeter, and we are going to give it 3 points. And I do think that the most challenge we face it when we use the TI-RADS to tell, is this true calcification or not? So as I mentioned, when you have calcification with large cometal artifact greater than 1 millimeter, this came with the cystic nodule, you will give it 0 point. And sometime you will have linear echogenic line, and this just it will be due to the interference of the tissue component of the nodule itself, and you will give it also 0 point. Macrocalcification and peripheral calcification, it was clear. And for punctate, either like this or like this, and you will give it 3 point. So the question it will be, is this real calcification or not? So if we concentrate, we'll find that we have large cometal artifact in all these echogenic foci. So I think we have nodule with cystic space more than 50%. So we have cystic nodule or spongiform nodule. So the answer it will be no. Here also we have a nodule with some linear echogenic foci, and this, as we said, due to tissue interference. So now I will go through some cases to discuss it with you, and I do believe that TIRAD it is something practical. So if you don't start to use it, better to start use it, and if you use it, try to use it more. Just be familiar with the TIRAD chart, put it in your room when you're scanning the patient, and start to apply it. So here, the first case, I think we have a cystic nodule, so we are going to give it 0 point for the composition. And when we start with 0 point, it means the echogenicity will give it also 0 because it is an anechoic. The shape and the margin and the echogenic foci, all it will be 0. So here we have nodule corresponding to thyroid 1, which is benign and no need for FNA. So here the question it will be, is it solid or spongiform? And if we concentrate, we can see that the cystic space more than the solid component. So we have spongiform nodule. We are going to give it 0 point, and it will be corresponding to thyroid 1. Here for the composition, I think we have a solid nodule. For the echogenicity, when I compare it with the thyroid, we can see that it is an isoechoic to the thyroid. So we are going to give it 1 point, and it is look wider than taller, well-defined margin, and no echogenic foci. So it will be corresponding to TIRAD 3, which is greater than 1.5. So nodule like this. The maximum diameter here we have 2.9. So this patient, we recommend FNA for him. Here also I think we have a solid nodule with few cystic space. When we compare it to the rest of the thyroid, we can observe that it is hypoechoic compared to the adjacent parenchyma. So we are going to give it 2 points for the echogenicity, and it is wider than taller, so we'll give it 0 point. It has a smooth margin, and we'll give it 0 point. So no echogenic foci, and we'll give it 0 point also. So we have 2 for solid and 2 for hypoechoic. The overall score is 4, which corresponding to TIRAD 4. In this case, we'll do FNA if the largest diameter greater than 1.5, and actually it is 1.9. So we will recommend FNA for this patient. So here, I think we have solid nodule. We are going to give it 2. And the echogenicity, when I compare with the rest of the thyroid, it appears hypoechoic. I will give it 2 points also. And the shape is wider than taller, so we'll give it 0 points. And the margin, it look ill-defined or smooth, it doesn't matter, I will give it 0 point anyway. But this nodule, it has macrocalcification with acoustic shadowing, and also it has dot-like appearance, which it means there is microcalcification. So as I mentioned earlier, for echogenic foci, you can add more than 1 feature. So we'll give it 1 point for the macrocalcification and 3 points for the microcalcification, and it is solid and hypoechoic. So we have 4 and 4, 8, and this corresponding to TIRAD 5. And the nodule is greater than 1 centimeter, and actually this patient, he did FNA, and this nodule turned to be BTC, papillary thyroid carcinoma, and he did partial thyroidectomy and removed the right lobe of the thyroid. So this patient came to us, complained of neck swelling, and she have been until tender during the scan. So we took this hypoechoic area as nodule, which it measured 2 centimeter. So if we apply the TIRADS here, we'll consider it solid, hypoechoic, so it will be corresponding to TIRAD 4 and it's greater than 1.5. Here I have seen a clip for the same patient. I think I have problem with the scenic lab, it didn't work. Anyway, this patient, she did FNA, and the result, it was subacute thyroiditis. And later on, it developed the same texture in the right lobe. So the idea, the clinical correlation, it is very important. So if you have patient tender, suddenly he have pain in the neck with swelling, and you have area hypoechoic, I think you have to follow it before you do the FNA, and you have to consider the subacute thyroiditis. So here we have a solid nodule. It look hypoechoic when I compare to the rest of the thyroid. It's wider than taller with ill-defined margin, and it has microcalcification. So the overall score, it will be 2 for solid, 2 for hypoechoic, and 3 for the punctate echogenic foci. It will be 7, which corresponding to TIRAD 5. And also this patient, he did FNA and turned to be BTC, and he did partial thyroidectomy. Here the patient in the follow-up. This is the right lobe bed, and this is the left lobe of the thyroid. Here we have a nodule, and what we can observe that by visual inspection, the AB diameter is greater than the width, and this it means invasion. And actually, the internal jugular vein here, it has tumor thrombosis. If we see it here in the sagittal plane, we have the internal jugular vein. It has thrombosis. There is vascularity with the thrombus. It means it is tumor thrombosis, and it has macrocalcification. So definitely we are dealing with something aggressive. So we have a solid nodule, hypoechoic, taller than wider, will give us 3 points with well-defined margin, and it has micro and macro calcification, which corresponding to TIRAD 5, and this, of course, it will turn to be something malignant. Here we have a solid nodule, and it look very hypoechoic. So if I compare the echogenicity with the thyroid, it is hypoechoic, and also when I compare it with the neck strap muscle, it look hypoechoic compared to it. So I will give it 3 points for very hypoechoic. This nodule wider than taller, it has well-defined margin, and it has punctate or microcalcification, so I will give it 3 points. So we have 2 and 3 and 3, 7, corresponding to TIRAD 5. And when we scan the cervical lymph node, we find that we have this metastatic lymph node with degenerative change. So here we have another solid nodule, hypoechoic. If I compare it to the echogenicity to the rest of the thyroid, I will find that it is an hypoechoic. It is wider than taller. Here I think we have lobulated margin, so we'll give it 2 points for this lobulation and no echogenic foci. So we have 2 for solid, 2 for hypo, and 2 for this lobulation. The overall score, it will be 6, which is corresponding to TIRAD 3. I will do FNA if the largest diameter greater than 1.5, and here the diameter is 2.6. So this patient he did FNA. Here we have a solid nodule. It look hyperechoic when I compare to the rest of the thyroid. It's wider than taller, with well-defined margin, no oncogenic foci. So I have 2 for solid and 1 for hyper. The overall score it will be 3, which is corresponding to TIRAD 3. This nodule, the largest diameter 1.4. So nodule like this, no need even to follow it because it is less than 1.5. So here we have a solid nodule with macro and micro calcification, hypoechoic, wider than taller. So we'll give it 2 points for the composition, 2 points for the echogenicity, 1 point for macro calcification, and 3 points for micro calcification. The overall score it will be 7, which corresponding to TIRAD 5. Actually, if you are sonographer, you can use the cine clip for the radiologist. It will help sometime if you need another eye or the radiologist need more view for the nodule. So the question here it will be, is this solid or spongiform? And as I mentioned, you can use the color box, and if no vascularity, it means you are dealing with spongiform nodule. So here for me, I think we have cystic space more than 50% of this nodule. So we are doing with spongiform nodule, and it means it's 0 point, and it is corresponding to TIRAD 1, which is benign. Here we have another nodule similar to the last one, but here you can feel that the solid component it is more than the cystic space. So here we have a solid component, and when we put our color box, there is vascularity. So we have a solid nodule with echogenicity, I think, isoechoic to the rest of the thyroid, wider than taller, with well-defined margin, and no oncogenic foci. So the overall score it will be 3, which corresponding to TIRAD 3. And the greater diameter, it was more than 3, more than 2.5. So we recommend FNA for this patient. And actually the patient, he did FNA, and it turned to be, he have malignant nodule, and he did partial thyroidectomy. So the last case I have for today, here we have a solid nodule with echogenicity. If I compare to the thyroid, hypoechoic, it is an wider than taller, with a smooth margin and no oncogenic foci. So the overall score it will be 4, which corresponding to TIRAD 4, and it's greater than 1.5. So we recommend FNA for patient like this. So this all the case which I have for today. The TIRAD they bring for us template for their report, and actually I do believe that this report make us all work in the same frame, in the same way. Before, if I scan patient and we have nodule, just I will start to describe it, and maybe I will recommend FNA, and sometimes even my colleague he can recommend nothing at all. So the TIRAD report it will be like this. I will mention the maximum diameter, the location of the nodule, then I will go through the all category. After that, I will mention the total point and the corresponding TIRAD level. And if the nodule for follow-up, I will mention if there is significant change in the size, if there is change in the feature, if there is change in the TIRAD level, and at the end, I will write the recommendation, either FNA or follow-up. And for follow-up, actually, we'll follow for 5 years, and it will be every year for nodule with TIRAD 5. For nodule with TIRAD 4, it will be in the first year, and second year, and third year, and then the 5th year. For nodule corresponding to TIRADS 3, I will follow in the first year, then in the third year, and then at the fifth year. Uh, if you want to be more familiar with the TIRAD, there is an application. You can find it in the Google Store or Apple Store, whatever the phone you use it. You can download it. It will open for you like this. Then you will choose each category and start to add points. Like here, if I press here in the ecogenicity, it will give me option. I will start to choose and fill all the option. Then it will give me the result, whatever it is, TIRAD 5 or 1 or 2, and it will give me the risk of malignancy and what the recommendation for that. Uh, at the end, TIRAD, it is a guideline, not something standard. So sometimes we have special scenario. We have to do FNA, even if the TIRAD score not matching to that. Like if we have patient, he did PET CT for any reason and there is uptake in the thyroid, so you have to do FNA anyway. If you have next suspicious lymph node, you have to do FNA for the thyroid nodule, and many different scenario. So at the end, the TIRAD, it is an point-based system. Only report the nodules that meet criteria for biopsy or follow-up. Save the time by recognize nodule that can be dismissed, like if you have an cystic nodule or spongiform, or if you have a nodule with TIRADS 3 but the maximum diameter less than 1.5. And actually in the TIRAD report they recommend that only to report 4 nodule, the most 4 suspicious nodule, and only we recommend FNA for the most 2 suspicious nodule. So that's all what I have today. And if you have any question or concern, you can type it and later on I will answer it. Thanks to all of you.